Okay, so this topic is a topic that is one of my favorite topics as a physician on sleep. And I'll tell you some stories that personal stories of mine on sleep as we proceed. So this is just a general outline of the talk for today. We're going to go over some just basics about sleep, some of the basic mechanics. We're going to talk about what happens with sleep as we age, and then how sleep and cognition are related, how important they are. And then finally, we're going to be talking about insomnia, because this is one of the most problematic issues with sleep. We're going to talk about some of the causes and treatment. And then hopefully all of you can go home and we'll go over some basic take-home points. So most of us, if you're like me, we spend about a third of our lifetime sleeping. Of course, for me, sometimes I wish that I don't have to sleep as much, because depending on how busy I am, I go, wow, I'm wasting time. Other times I'm tired and I go, well, I need to make sure I catch up on my sleep. But I think it is important to step back and say, well, why bother? Why is sleep so important? Okay, so I hope most of us would understand that sleep is important. It is crucial for everyday functioning, right? There's a lot of different theories of why we need to sleep. Some people look at it from a developmental perspective, that sleep is important as we grow, that in fact, especially for children and teenagers, they're probably growing in their sleep. Right? From a neurological perspective, we look at it as that is the time where the neurons get their rest, that they get to rejuvenate. They develop those synapses, they prune, they fine-tune the connections. And in memory, sleep is important for memory consolidation. So just going back, sort of a little funny cartoon, nowadays kids are so busy. They're constantly on it used to be their video games, now they're always on their iPhones, right? So they're so busy that sleep, the kids are constantly deprived of sleeping. And all of a sudden there's this parallel growth in the diagnosis in this, my child has ADHD. They're inattentive, they're misbehaving in school. As it turns out that if you can address the sleep issue, because again, sleep deprivation means that it causes memory problems, it causes inattention, it causes mood, irritability, and restlessness, that if you can focus on getting the kids better sleep, that the ADHD, a portion of those diagnoses of ADHD can potentially go away. The other aspect that's sort of related to sleep is this issue with obesity and sleep apnea. Our kids are gaining weight. There's increased risk with weight gain, a thicker neck. And we know for a fact that a thicker neck means that it increases the risk of sleep apnea. So what they found in kids, in terms of this diagnosis of ADHD in kids who are overweight, if you can fix their sleep apnea by encouraging weight loss, their sleep apnea improves. So about a quarter of those people, their diagnosis of ADHD actually go away. So as you can see, the complexity between a medical condition, sleep, and then behavioral issues. So this is a sort of a somewhat complicated diagram, but I do, my goal for you to learn one complex word today, and that word is a very long word called the suprachiasmatic nucleus. So you all have to learn, this is your neuroanatomy of the day. Suprachiasmatic nucleus. So why is that important? So all of you can see that that's on the left top corner, that word. So what does that area do? So that area is responsible for our biological clock, responsible for the circadian rhythm. So what sets our sleep? Sunlight reaches, going through our eyes to our retina, and the suprachiasmatic nucleus senses that sunlight and sets our biological clock. And keep that in mind. Later on, I'll point out to why it is that sunlight is so important in terms of sleep. So this is a major regulatory center that regulates sleep. So there are a ton of neurotransmitters that are responsible for sleep. This is as much as I could try to simplify. I don't worry about all these terminologies. I just wanted to sort of illustrate and give some examples of some of the neurotransmitters or neurohormones that are involved in sleep. So all of you would know about melatonin. So the neurotransmitters on the right-hand side, they tend to build up over time. They build up during the day, and as their levels increase, those are the neurotransmitters that help us go to sleep. So melatonin is a perfect example. During the day, we slowly build up our levels of melatonin. Helps us go to sleep. The levels actually go down at night. Adenosine. So adenosine similarly build up during the day, and it goes down at night. So adenosine is one of these neurotransmitters that we are actually, most of us actually externally manipulate. Okay, so caffeine is an adenosine antagonist, meaning that it blocks adenosine. So most of us sort of artificially affect our sleep drive by dampening the effects of adenosine so that we're more awake. So that's the same reason why I sort of pointed out all these neurotransmitters, because there are a lot of medications that affect these systems. So all the neurotransmitters on the left-hand side are neurotransmitters that are contained in a lot of psychotropic medications. They tend to they're wake promoting, meaning that they make it hard for you to go to sleep. Because of that, these compounds can potentially cause insomnia. Okay, so the first three, serotonin, norepinephrine, and dopamine, they're contained in our antidepressants. Histamine, we'll talk about later. It's wake promoting, but antihistamines are medications that a lot of people take to help them go to sleep. That's the product containing in a lot of PM products, Tylenol PM, for example. So let's go back to normal sleep. So what is considered normal? So normal, there's really normality in biology is really what is the average, right? So because we're not sure what is exactly normal, but we look at, well, normal is what most people do. So over time, as we age, the need for sleep decreases. So infants, they're probably sleeping about 18 to 20 to maybe even 22 hours a day when they're first born, and then that number goes down over time, maybe to 14 hours, 12 hours for the toddlers. But the number of hours that we all need to sleep, it tends to plateau in adulthood. So usually around age late 20s, 30s, that number plateaus. And for an average adult, it's about 8 hours. Now there's a range. Some people, they are fine sleeping 6 hours. Some people need 10 hours of sleep. Now I will say though, Occasionally, I will run into people who say, well, I only need 4 hours of sleep. And I've been that way for years. Those are sort of the outliers. Usually it's not that low. I haven't seen anyone who says, I need 14 or 16 hours of sleep. Tends more, even the outliers tend to run on the low end. So sleep latency. So sleep latency just means the amount of time that it's required for someone to actually fall asleep after they get in bed. Usually it's about 10 minutes. That's a time that can be sort of in the upwards of hours for people who suffer from insomnia. And that's an area that can be very distressing for people. So a lot of the medications that are out there, they measure their effectiveness or their outcome on sleep by lowering the sleep latency, reducing the amount of time it takes for someone to fall asleep. Can't talk about sleep without talking about the different stages of sleep. There's about 5 different stages, but they could be simplified into 3 stages. There's the shallow sleep or the light sleep, and then there's the deep sleep. There's 2 kinds of light sleep and 2 kinds of deep sleep. And then another kind of sleep that we all know about, which is REM sleep or rapid eye movement sleep. That's a time where it's a dreaming state, where during REM sleep, your body sends signals to paralyze your muscles. So even though your brain is extremely active during REM sleep, you can't not move. And there are issues when the REM sleep is disturbed. Some people get different types of REM behavior sleep problems. So those conditions are pretty rare. But again, in short, there are 3 major stages of sleep: light sleep, deep sleep, and then REM sleep. Just some diagrams. So on the top, it's the different the light stages of the light sleep. There are 2 different types of light sleep. You see that the little squiggly lines. So during light sleep, it almost looks like the person is awake. Okay, this is from the EEG electrodes attached to the brain, showing activity in the brain. Okay, so the light sleep is similar to person is awake. The deep sleeps, stage 3 and stage 4 sleep, the brain activity actually increases during deep sleep. But there's fewer squiggly lines. So what it means is just that there are certain areas in the brain, certain neurons are way more active than others. That for the most part, most of the neurons are inactive, but the ones that are active, they are very active. And then REM sleep, it looks just like the person is awake. There's a ton of brain activity, but then the person is paralyzed. They don't move. The muscles are paralyzed. So what happens as we age? So as we age, the amount of REM or dream activity actually is reduced over time. The amount of time needed to go to fall asleep is increased. And then as we age, there's more awakenings that throughout the night, the individual they're more easily awakened. Okay, now we want to think about, well, what happens when someone has dementia? What happens when there's amyloid buildup? You've all, hopefully through our Alzheimer's Disease Center lectures, know about the relationship between amyloid as the main cause of Alzheimer's disease. This is a diagram that essentially illustrates the relationship between sleep and amyloid. So on the right-hand side, there's a lot of this dark orange, red, glowing this is an imaging of the compound that attaches to amyloid and produces this image. So the brain on the right shows a lot of amyloid activity. The one on the left-hand side, there's almost no sort of orange-red color because there's very little amyloid. And what we see here is that for the image on the right-hand side, the sleep is different than the one on the left. On the left-hand side, there's a lot of, the activity shows deep sleep, as I showed you earlier, right? The lines are larger and they're higher in their length. The one on the right, there's a lot of squiggly lines, sort of like someone is awake, that's the light stage of sleep. So what they found was that in people with a lot of with amyloid buildup in certain parts of the brain, certainly not for everyone with amyloid buildup, but in some people with amyloid buildup, that their non-REM deep sleep, their deep sleep is reduced. This is a research that came out of UC Berkeley from a group that's actually from Dr. Bill Jaga's group, who was our founding director of our UC Davis ADC, and then he moved over to UC Berkeley to do more research. What they found was that they did some research, and they put a group of people. I'm going to go back to this diagram, and they found that for the people on the right-hand side, there are people with amyloid buildup, and there's a gradation that for the people with amyloid buildup and much less deep sleep, that of those individuals, if their sleep was disturbed, they have very few deep sleep, because again, I sort of made it a little too simple, but it turns out that some people with amyloid, they actually sleep fine. It's just that the more amyloid you have, the worse is your sleep. And what they found was that of the people with a lot of amyloid and not a lot of deep sleep, that those people have specific problems with their memory. They challenged these people to do certain cognitive testing. And those people have problems with forming memory in their hippocampus. However, in the people with relatively normal sleep, their memory formation was not as affected. Okay. So this is somewhat of a complex study. And so this is the UC Berkeley study is fairly novel, but it sort of conforms to this overall theory that sleep and Alzheimer's pathology, that sleep and amyloid pathology is actually a bidirectional relationship. So another way of looking at it is that this is sort of unfortunately, a vicious cycle. That if you have amyloid buildup, the amyloid can affect certain parts of your brain that it regulates sleep. So for example, the pathway that is involved in that particular word that I asked you to remember, the suprachiasmatic nucleus, that's a fairly complex pathway, and if you have amyloid buildup in that pathway, people develop sleep disturbance. Now, of course, dementia itself affects behavior then also worsens sleep. And then going back to sleep disturbance, if you have sleep disturbance, something like obstructive sleep apnea, you don't get enough oxygen, that could potentially damage your brain, and that could cause inflammation in your brain. And in turn, that causes amyloid buildup. So sleep and memory impairment is, if you have problems in both of those, it is a vicious cycle. So people are starting to think that if you could help by improving people's sleep, because that's something that you could work on. Now, of course, there's a lot of research on amyloid to find a cure for Alzheimer's disease is to find the amyloid in the brain and destroy it or block it. Another potential pathway is to just work on improving sleep. This is just a quick quiz to wake people up. So which of the following, I should say, are true? I shouldn't say is. So you burn more calories sleeping than you do watching TV. That's true. Amazingly, sleep is a fairly active process. It's not passive. So sleep is important in restoration of brain neuron activity. We talked about that. That's true. Amyloid deposition likely affects sleep. True. Insomnia is a common problem. Turns out they're all true. Okay, so now I want to talk about insomnia. So insomnia occurs about probably at least half of older adults. So it's a very common problem. Tends to have, be a bigger problem in women than men. Those are some of the risk factors for insomnia. And one of the reasons why, as we age, insomnia becomes a bigger problem. As you can see, there's issues with depression and anxiety that could affect insomnia. Medications can affect insomnia, as remember we talked about some of the neurotransmitters. And then physical health problems. So as we age, you start to have more health problems. Sometimes you have mood issues, and then your medications certainly go up. So just, the cards are stacked against older adults in terms of having insomnia. Here's just major causes of insomnia. So it turns out that about half of the causes of insomnia are psychiatric causes that range from depression to anxiety. Then you put that aside, but another quarter is medication related. So medications could be certainly medications that keep people awake, but also things like diuretics. Right? If you have to take a diuretic, that's going to wake you up quite a few times in the middle of the night. Right? So this primary insomnia is actually a small cause of people of all the insomnia. So primary insomnia means that you have problems with falling asleep for about 6 months, and it's not clear. It's not due to one of these other reasons. And then there are a small minority of people have this, sleep disorders that keep them up at night, but that's a very small minority. So I do want to talk a little bit about depression and sleep. So what is depression? So a lot of people sometimes just say, well, I'm depressed. And I will say I see a lot of people with depression. Those people actually don't have depression, the clinical major depression. Because depression, clinical depression is a phenomenon. It is a mood issue where a person has to be in that depressed mood for at least 2 weeks, usually even longer. It is not when someone hears bad news and they become depressed. That's a normal reaction to bad news. So insomnia is a common problem in people with depression in that they have a hard time falling asleep. They often wake up several times a night because of their depressed mood. And then once they wake up, more often than not, they're not able to get back to sleep. They're often up at 3 or 4 a.m. and then they're done. They can't go back to sleep. Often folks with depression, you can see it on their face that they're depressed. Almost nothing will seem to be able to cheer them up. They're not interested in doing things that they usually like to do. Certainly they have concentration problems and low energy. In older adults with depression, it may seem like they have dementia, that their cognition is so bad. And they're also not eating and certainly not sleeping. So this is somewhat of a tangent in terms of, I've alluded to the sleep apnea issue. So what is obstructive sleep apnea? So obstructive sleep apnea is a condition where if you were to put someone on a monitor their sleep on an EEG overnight, you see that they're actually not breathing, or they have reduced or very poor breathing several times during the night. Several times during the night, such that they're not getting oxygen. Now, the snoring component comes where the person is, their airways are pushing very hard to get oxygen. That they're forcing their airways, and that's why there's that loud noise. Now, what will happen is if you ever suspect someone with sleep apnea, you certainly want to go get a sleep study. But also, if you notice, if you watch those people with sleep apnea, that there are periods during the night that they're not breathing. It's quite scary. And because of that, they're not getting restful sleep. So during the daytime, they're often drowsy. It's very easy for them to just fall asleep. If they're reading, you find them falling asleep. They're watching TV. Anytime they're doing passive activity, they fall right to sleep. And this can happen up to a quarter of older adults. You know, one of the major risk factors, as I alluded to earlier in children, is obesity. And this can potentially affect up to half of those people with dementia. So you can see that the obstructive sleep apnea and then dementia and sleep, again, that plays a big role in older adults. If you're not, we call that for kids who have sleep apnea, it looks like they have ADHD. In older adults, of course, it looks like they have memory impairment, they have confusion, they're disorientation, they can't concentrate. So going back to insomnia, so what do you do if you're not sure about what to do about your insomnia? So it's very important, before you even go see a doctor, you want to do a self-assessment. So you want to go and look at, has there been any major recent stressful events, any major environmental changes, right? When there are a lot of life stressors, it's going to affect our sleep. And sometimes that insomnia is actually normal. It's a normal reaction to a stressful event. And for normal reactions, you probably don't want to do too many things about it, because it's normal. And then the other part is, you want to look at, has there been any recent changes in your dietary habits or in your medications? Because that's usually the most common causes of insomnia. Okay, so I'll tell you a little bit about myself with insomnia. So people, I would say, doesn't happen to everybody, but I often tell my colleagues, during some of my most important exams, this is when I was in medical school, I would be up all night. I would try to go to sleep, and I cannot fall asleep. And I would say 2 of my most important exams, I was up in bed for the entire night. And it would frustrate me. I would feel terrible about my performance on the exam. Often, I'm quite sure I didn't do as well as I could if I had slept well. But in retrospect, when I look at those instances, I also sort of set myself up for the insomnia. What I was doing is I was super pumped up. Maybe not excited about the exam, but I was super pumped up about studying. I would at least study till 10 a.m., 11 a.m. When we're in medical school, it's not uncommon to be essentially hooked up to an IV drip of caffeine. So it really didn't need to see a doctor for my insomnia. it's quite common that it was quite readily obvious that if I had really looked back at it, I really needed to just cut back on what I was doing for, as well as my own, my sleep hygiene in terms of not drinking caffeine at night. My studying habits, not studying the night before an exam, studying giving myself time to learn and not cram for an exam, especially important exams. So going back to this assessment of insomnia, you want to look for your own stressful events and look for ingestions. And then finally, when you do go see a doctor, they're probably going to look at perform a physical exam just to look at some of the risk factors that you have for insomnia. They might want to work you up for sleep apnea. And then finally, keeping in mind half of the causes are potentially psychiatric to really be evaluated for depression and other mood conditions. So here's just some basic treatments for insomnia. They could be sort of separated in a few major categories. The first one is just sleep hygiene, making sure that you have good sleep hygiene. There are some specific behavioral treatments for insomnia. And then addressing if there are any medical or psychiatric problems. And then medication use should really be limited. We'll go over a few of them. So this is sleep hygiene. What is sleep hygiene? So you want to avoid naps. Napping tends to fragment your sleep. And this is not to say that you can't have a siesta. It's more the frequent naps, the napping when you feel tired, the napping that is not a routine, that is sort of 3 or 4 little cat naps. Bedtime should be consistent. The bed is not an office. You don't want to be, working in your bed. It's also not a good place for TV watching. Exercise is important for sleep as it is for sort of memory. Don't watch the clock. So especially during the clock becomes an anxiety-provoking stimulus when someone has insomnia. Because what happens is you're gonna watch the clock. You can say, "Oh boy, I'm still up. It's midnight. I'm up." Before you know it, it's 1 a.m. You're up. Before you know it, it's 3 a.m. And all of a sudden, you're up the entire night. I've done it. You don't want to watch the clock. I can attest to that. Doesn't help because it just increases your autonomic arousal. Makes you even more anxious and beating yourself up for not able to sleep. Of course, you want to make sure you don't eat too much or too little. You don't avoid caffeine, avoid nicotine, avoid stimulants in general. And then alcohol. Alcohol also fragments your sleep. It reduces the quality of your sleep. So you don't want to be relying on alcohol to help you go to sleep. It can become a big problem because over time, dependency issues happen. But also, there's good research out there showing that alcohol fragments people's sleep and it reduces the quality of your sleep. A few interesting behavioral treatments for insomnia. So stimulus control is a technique. It's very technical, but basically what it says is you want to manipulate the environment so that the environment helps the person go to sleep, and the environment does not cause the insomnia. So an example would be keeping a TV in your bedroom. Having a TV in your room weakens the association between the bedroom as a place for sleep. Because all of a sudden your bedroom becomes sort of a living room. That association is very important. It's also very important in people with dementia because if you, that's the whole point of environmental manipulation is if you go into an area and that signal is clear that that is the place for sleep, and nothing else, it sends the signal that, hey, it's time to sleep. And there's all different kinds of environmental manipulation that you could do to send that signal that, hey, it's the ritual that promotes sleep. So paradoxical intention is a fancy term for reverse psychology. So reverse psychology is where you trick your brain. So I've used this on myself, where if, now fortunately I don't have to take too many difficult exams now, but there's occasionally where I can't fall asleep for different reasons. I would trick myself and say, you know what, I've been through this before. This is what I'm gonna do. I'm gonna tell myself that I'm gonna stay up for as long as I can. I'm gonna try to count it, but I just kind of tell myself that I don't need to fight this insomnia. I'm just gonna stay up. And every time I do that, I forget to keep track of how long I've stayed up. I fall asleep. Why? Because what happens is when you trick your mind about that you're no longer concerned about that performing the task of sleeping, you actually can do it. When you keep telling yourself to do something, it generates a lot of anxiety. Okay, so reverse psychology is a quicker way. It's almost like sheep counting. You count the number of sheep, and pretty soon you get so bored and you're not thinking about that you have to sleep. You can fall asleep. Relaxation. This is sort of the technique of just reducing your autonomic arousal, that you're so used to being energized that if you calm yourself down, there's certainly more complicated techniques like biofeedback, but if you meditate or you do something that's more monotonous, you can fall asleep. Cognitive behavioral therapy is almost like reverse psychology, but it looks at the cognition, looks at distorted cognition, your own beliefs, your false beliefs about why you can't fall asleep. So a lot of people have developed, people with chronic insomnia, they develop false beliefs, statements like, well, if I can't fall asleep, I'm going to just have a miserable day tomorrow. So what does that do to your brain? It sort of sets yourself up for having a bad day tomorrow. Which often case is not true, because most people with insomnia, their day certainly may not be 100% where they would like it to be, but they're usually at least at about 80% of where their peak performance is. But when you start beating yourself up about how your sleep is ruining your life, it contributes to that insomnia. So we're going to switch gears and talk about medications. Over-the-counter medications, this is products that contain, for the most part, Benadryl or diphenhydramine, the PM products, relatively contraindicated in older adults, definitely in people with dementia. Because what happens is this group of medications, they can cause confusion, they can worsen memory, and they can increase the risk of falls. Sedative hypnotics. This is the Z drugs. This is a typical medications that if you have to go to a hospital, because that hospital environment does not condone sleeping, you get on that medication, and all of a sudden it helps with your sleep, and then you start to rely on it. Or that a person goes into the hospital with different issues, their doctors forget to stop the medication, and then they continue on it at home. So this group of medications, just like the other group, except they're stronger and they have this risk for the person becoming addicted to these medications. If they were to stop the medication, all of a sudden this person goes into insomnia. They can in fact even become more agitated. Then of course you start the medication right back. Then all of a sudden you tend to rely on the medication. But then it causes problems because pretty much all the sleeping medications, they can worsen cognition. They increase the risk of falls. This particular class of medications, they can also suppress the sleep drive, so that they can worsen people's sleep apnea. Melatonin for the most part, is something that most people actually, interestingly, don't become addicted to it. At the same time, it doesn't always work. So it particularly does not work for people who have intermittent insomnia. For example, if you can't sleep at that moment and you feel like you need to go to sleep so you can perform the next morning, melatonin tends actually to not work very well in those situations. It doesn't work in the acute or in the acute setting. So melatonin is that product that we often know that people say they're in a food coma. There's also branded medications that act on the melatonin receptor. It certainly causes people to fall asleep quicker, and it could improve. It's one of the few medications that improves sleep efficiency. It doesn't have a potential for abuse, a very low potential. But again, it doesn't always work for everyone. So now we'll talk about what to do with people with insomnia with dementia. So again, going back to the sleep hygiene, you want to avoid too many naps. It is important to have sunlight exposure. So remember that suprachiasmatic nucleus that regulates sleep. You don't want to have the person being in a room with no sunlight for too long, right? Because that changes their sleep drive. Exercising obviously is very important. You don't want them to have all their energy left at the end of the night, where they can become more agitated. Having that bedtime ritual, right, that stimulus control or environmental modification is very important. If you send all the right signals, you get the right music and you get the right scent, you get the right ritual, the bathing ritual, this is the time to go to sleep. And then finally, in people with dementia, though, it is very important to go over their medications. A lot of times, sometimes it's changing the timing of the medication. The medications that causes someone to, that causes insomnia in someone, all you have to do is just move it to the morning. So finally, just a few take-home points. So if insomnia were to happen, and this is something that it's not chronic, it just happens, you want to go over just your routine. What's changed? What's changed in terms of activity? What's changed in terms of what you're ingesting, medication-wise or food-wise? For the most part, for the treatment of insomnia, you don't want to use a medication. You want to use the body's own rhythm. Let the body work and adjust. And then finally, some good sleep hygiene. I gave you a list of 8, which is a lot, so I'm just going to really go over 3 that most people have found very helpful. The first one is don't watch the clock. If you struggle with insomnia, get rid of it. Get up at the same time each day. Even if you're very tired or if you're sleeping well, if you set that routine, you help that biological clock with a routine that says you get up at a certain time. You don't change it just because it's a weekend. That will help your biological clock. And then finally, don't lose sleep over not sleeping. That's a reverse psychology. Don't set yourself up for insomnia.
Hi, I was wondering, you said that sleep aids can cause memory loss or dementia. If you stop taking those sleep aids, does the memory then get better? Can you improve?
It certainly can. So you're talking about the sleep medications. Yeah. Yeah. So the sleep medications, because even in younger people, if you put those people on those medications and you were to test their cognitive performance is going to go down. So in someone with dementia, I'm not saying you for some people it becomes sort of a benefit risk. If they absolutely cannot function with their sleep medications, then obviously you need to be careful with just taking it away abruptly. I would say that you want to make sure you do that under the guidance of a physician. But yes, if you can get rid of that medication, certainly there's a chance that the cognitive performance will improve. Now, for someone who has very severe dementia, you may not be able to tell when there is improvement, however. So it just really depends.
I have two questions. On one of your slides, it said melatonin generated from amino acid tryptophan and serotonin, and then in parentheses it said pineal gland. I didn't understand that, the pineal gland.
That's just the location where the melatonin is generated.
Okay, okay. So all of these, the melatonin, the tryptophan, the amino acid, serotonin, is stored in the pineal gland?
They're not. Melatonin itself, it's predominantly generated in that area. But no, the other area, the other neurotransmitters are all over in certain parts of the brain.
Okay, just the melatonin. And then the second question, when you were talking about amyloid buildup.
Yes.
What is amyloid buildup, and how do we get that? And how do we get rid of it?
That's what we want. That's what we want to do to cure Alzheimer's. So amyloid is the compound that is the result of brain degeneration. That's the compound that causes Alzheimer's disease. And currently, there's active research, and I think we're getting closer and closer. And this is one of the main missions of our center as well, is to find a cure for Alzheimer's disease. And there's been many different approaches to try to figure out how to reduce amyloid buildup, or how to get rid of amyloid from the brain.
But how do we get it to begin with?
Or in terms of why, that's very complicated. You're going to have to come back to another lecture about dementia. It's quite complicated, and we don't have all the answers, but I think we have a lot of the answers.
My question's about melatonin. If
Yes.
you take it at first to aid your sleep and it doesn't work, is this something that if you keep on taking it, it will build up and will help you if you're consistent about taking it later on?
That is certainly quite possible, because again, and that's the same reason why it doesn't have that or very low addictive potential, is because it doesn't respond to people's expectations, but over time that it can work.
And then I had one more question about the Benadryl. That is sometimes used as a sleep aid, but does that interfere with sleep?
And so again, for most people, it does help with sleep, but it's more the memory, the side effects of the cognition. That just like when you take the Benadryl, you're going to have a problem with thinking. You become drowsy. And for a lot of people, it carries over into the next day where they're not at peak performance. So imagine if you have someone with memory impairment and you give them a Benadryl, the next day, they're not going to, their cognition even, gets worse.
I was under the impression that the presence of amyloid in the brain, that it had not been established that it was causal, though it's clearly is associated with Alzheimer's. But you said it's the cause. Now I want you to clarify, please.
Yeah, I mean, so there are other, there are actually two major pathologies that we find in people with Alzheimer's. One is the tangles, the other one is the amyloid plaques. And so I think a lot of people are thinking, well, are you certain that that is the cause? Could there be some other cause? Of course, you can also go back down and say, well, there are other things that causes amyloid. So the amyloid is just an associated finding. So I think you're absolutely right that, are you 100% certain that that's the sole cause? Because we know that there are genetic causes of Alzheimer's disease, although the associated finding is also more amyloid plaques and tangles. So the one area that is becoming more certain is that there's been some research that have shown that if you could reduce people's amyloid, there's signals that their cognition improve. The drugs that were developed, however, also cause a lot of neurological problems, which is why they haven't been quite marketed yet. So you're right that it's not an absolute cause, but I think, however, we're getting pretty close. If we could get rid of the amyloid, I think that most people who are researchers these days are confident that that will improve people's cognition.
Hi, I have a comment and a question.
Yeah.
We have been learning a lot about blue light and light at night, and so we really got rid of a lot of light in our bedroom, and that's really helped us to stay asleep.
Yes.
And I keep talking to people, I keep having this conversation, they're telling me, well, I have to get up because I have to go to the bathroom. I'm asking are you waking up and then realizing you have to go to the bathroom? Or is it the other way around?
You're asking who?
Just people in general. I think if you stay asleep, your circadian rhythm is supposed to sort of suppress the bowel movement and the urination. And so if you were asleep, in a normal person who's not on a diuretic, who didn't drink a lot before they went to bed,
Yes.
I think they're waking up first. And if they could figure out why they're waking up, they wouldn't have to go to the bathroom every night.
I think you're onto something. I would agree with you. I would agree with you. So I think what it is again, it's the frequent arousals that we talked about, right? As we age, there's higher likelihood of more frequent arousals for reasons that we don't understand. What is causing those frequent arousals? Or, if you're awake and you just fall right back to sleep, especially, teenagers, they have pretty rough sleep, but they fall right back to sleep. So is it inactivity? So if you're more active during the day, you might be more awake, but you fall right back to sleep because you're tired, which goes back to, it's so important to have routine aerobic exercise.
My question, it has to do with those with Alzheimer's specifically,
Yes.
sundowners,
Mm-hmm.
and cannabis, and the use of cannabis for sleep. Is there research? Because anecdotally, it's out there.
Mm-hmm.
So I'm kind of wanting to hear what's the relationship, or do we know?
I have not come across any research that's rigorous in terms of using cannabis in people with dementia. I think, again, people are using cannabis probably for different palliative reasons. Certainly, we do know that this is more my other hat as a psychiatrist, that the cannabis in younger people certain components can increase the risk of distorted thinking, psychosis, hallucinations in people. But at the same time, most people don't get that reaction. So what happens in older adults, honestly, I don't know. Okay, one more.
I was wondering, what's the best way to kind of keep a person with dementia to help them fall asleep while using any type of medication, because the doctor says not to use medication on the patient?
Right. So, what is the best way to help someone with dementia go to sleep? And I think this slide. Oh, I think my slide is a little it's sort of quite complex in that it's got a lot of components to it, but I think it's important to, hopefully you could read this. So there's many components of it, and I think you want to institute as many of these components over time as you can, right? So for example, aerobic exercise. If you can get that person up during the day and be active during the day, that's going to help them sleep at night. Right? So if you're looking at the different environmental issues, if you want to make sure that bedroom is only used for sleep, that sends a signal. You want to make sure that bedroom is super, super dark. You want to make sure that person gets plenty of sunlight during the daytime. So those are just some of the sort of basic elements of sleep that affects all of us, but I think even more critical in someone with dementia, because they're not going to know how to do it on their own. So this is not easy to institute, because it requires a lot of caregiver time, right? Just to get that person active and getting them some exercise during the day. It's not easy to do. Okay, one more.
I was diagnosed with sleep apnea about 10 years ago. I went to a sleep clinic, and they told me that I should go on the machine, and I decided I didn't want to do that. So I guess I'm doing okay. So does that mean that I could possibly have the amyloid building up in my brain, because I am doing strange things lately? So what could I do at home to help myself?
Wait,
other
you're
than
doing
lose
strange
weight?
things lately?
You know what I mean?
Yeah, so I mean, you're not the only person with sleep apnea who does not like to wear their sleep machine. And again, it's not the primary treatment for sleep apnea is sleep, the machine, but also weight loss. Weight loss can help a lot of people with sleep apnea, because again, if you reduce the amount of the fat tissue around your neck, so that your airways don't have to work as hard to breathe, that's going to help. And some people, they figure out other ways to, there are other treatments, but you might want to, I forget your other comment about recently you're having some, you might want to take a look at that again, because with the sleep study, you might want to repeat it again, since it's been 10 years, just to see how many times a night are you truly not getting oxygen to your brain. Because not getting enough oxygen to your brain that's not good.
Something very scary happened to me. I woke up about 6 months ago, and I couldn't breathe. I was asleep, and I woke up, and it scared me to death. So my husband said, well, you need to go to the hospital. I said, no. But I haven't had that incident since. Now they told me that I had asthma, so the heck with it.
Yeah, again, most people with sleep apnea have several times, probably at least 5, if not 10 episodes during the night where they're truly not breathing, and they're not aware of it. Your situation is different, that you're aware of it. Most people with sleep apnea, they're not aware of the fact that they're not breathing.